Many thanks, Lauren, and a very warm welcome to today's launch event. Can we have the first slide, please, Lauren? So today we are launching our important joint thematic inspection of the criminal justice journey for people with a mental health need and disorder. This was published on the 17th of November, and it was the first time that all 4 criminal justice inspectorates had got together to inspect provision in this area since the joint review we conducted after the publication of Lord Bradley's report in 2009. So this was a really important chance to review progress since 2009, including against Lord Bradley's recommendations, and we were very pleased that he could join our expert reference group. I'm going to start today's presentation with a brief overview of our methodology and key findings, and then you're going to be hearing from Tony Hirst from the Police Inspectorate, HMICFRS, in relation to their findings in relation to the police response. You'll be hearing from Charlie Taylor about how prisons respond to needs of this group, from Avtar Singh from the Probation Inspectorate, who was the team leader for this project, about the CPS and courts inspection findings and what we found in relation to probation. And finally, you'll be hearing from Dr. Sarah Lewis from the organisation Penal Reform Solutions, who gathered some really powerful testimony from people with a mental illness who had gone through the systems themselves or were still in it. Next slide. Very quick word about the methodology that we used for this thematic. There was a huge amount of data and evidence that we gathered. Field work was undertaken in April and May of this year at 6 locations across England and Wales, and you can see the locations on that map on the slide. We mostly had to do the field work over remote platforms like MS Teams, but CQC and HMI prisons were able to conduct some on-site visits. In total, over 550 interviews were carried out with professionals working at every stage of the criminal justice system, and that included frontline staff, managers, service leaders, as well as judges. So the team spoke to prison governors, to NHS commissioners, mental health nurses, police custody staff, prosecutors, probation officers, and a whole range of other people. Each inspectorate looked at a service-specific sample of cases, but we were also jointly able to inspect a cohort of 45 cases known to have gone through every part of the criminal justice system to see how well the mental health needs of that cohort were identified and responded to at each stage. And as with all of our thematics, we also wanted to gather evidence from people who were going through the systems themselves, and almost 70 of those interviews were conducted. Next slide. You'll hear more about these findings as we go through the presentation, but very briefly, I'm going to focus on our findings in relation to the system as a whole. And I think 2 things in particular stood out. The first was that the identification of people with a mental health problem was very patchy across the system, with significant variation in the proportion of people being flagged as having a problem at every stage and even within different agencies, which means that the needs of thousands of people are being missed. And even when those needs are being identified and assessed, we found that information often isn't being passed on through the system, for example, from the police to the CPS and the courts, both because agencies and frontline staff aren't being adequately prompted to pass that information on, but also because of a misunderstanding of data protection legislation means that people felt they weren't allowed to transfer or share that information. A second key thing for me was that even where people are being identified and referred for help, we found that treatment provision is often inadequate and has got worse during the COVID pandemic. We were told in particular that there's an acute shortage of mental health beds for people in crisis needing inpatient treatment, and that services in the community had long waiting times and were severely disrupted by COVID. Having said all that, we did find some improvements at the front end of the process since 2009, and 2 of Lord Bradley's key report recommendations have now been implemented, including the national rollout of Liaison and diversion services to police custody suites. And except in exceptional cases, we found that people in mental health crisis are no longer being held in police cells while they wait for assessments. Other areas, however, are showing less progress. It's still taking far too long, for example, to transfer very ill prisoners to secure mental health beds. And it remains the case that Black, Asian and minority ethnic people are overrepresented in the criminal justice system. And we also know have a higher risk of mental illness. And we found a lack of specialist services for that cohort. Next slide. I think it's worth just very briefly reminding ourselves why it matters, this issue of people with a mental health problem going through the system. Firstly, because they are a very underserved population in terms of those mental health needs. Up to 24% of recorded crimes in police areas we found have got a mental health flag. 38% of the probation population have a mental health problem, nearly half of male prisoners. So there's a huge amount of need in this population, and often they haven't been getting adequate services up until the point they enter the system. We know that the experience of the criminal justice process itself can make people's symptoms and mental health conditions worse, and you'll hear testimony on that from Sarah later in this presentation, in particular the impact of police custody and court appearances on people's health and of prison. And we know obviously the very high rates of self-inflicted death and self-injury in prison populations, but also on probation too. Thirdly, mental illness can affect an individual's ability to understand and participate in the process, the criminal justice process they're going through. At the extreme, it can mean that they are not free to take part in that process. But even if they are judged fit to plead, people can often find it difficult to understand the process they're going through and need sufficient access to others to support them, whether that's appropriate adults in police custody or other support services in court. And then finally, and we give many examples of this in the report, the symptoms associated with mental illness can themselves trigger criminal behaviours or be interpreted as criminal, and that in itself leads to contact with the justice system, in particular at times of acute crisis. Final slide from me. In view of all of those reasons, in view of all those factors of why mental health is important, it is essential that we identify people with a mental health need at every point in the system, so that if they're missed early on, they're still picked up while they go through the court system or in probation and prison. And in the report, we give examples of effective work that's being done sometimes to do that, right from police arrest schemes to schemes in court to some good work which is going on in prisons and probation, and as well as areas of concern. The report flags areas of effective practice as well, which we think are worth disseminated. But let's start this presentation with the beginning of the process and the first initial stages as people come into contact with police at the front end. I'm going to hand over to Tony now to take us through that part. Tony.
Thank you, Justin, and good afternoon, everyone. Just for context then, how mental health interacts with policing is a broad and complex subject, and it's very difficult to inspect just the suspect and offender element because everything's so interconnected. One of the reasons I'm telling you that is because that's definitely the case when we talk about how this subject is led, and that was the first area we looked at, both at a national and a local level. So looking at the leadership of the wider mental health sort of agenda, we found significant focus nationally on vulnerability and mental health through both the National Police Chiefs Council and the College of Policing. Really is a significant element of their work. We found good and consistent national guidance from APP, that's approved professional practice if you don't know, from the College of Policing, and the MPCC national strategy. Similarly, the force mental health focus is strong, with leadership structures and governance to heighten awareness and drive improvements and reach all the relevant parts of policing. And we found that forces provide additional local policy guidance and training. One of the reasons I gave that little context at the beginning is, though, that in all of those above areas, training, guidance, national strategy, etc., the focus on suspects and offenders and how to deal with that offending is a lower priority than other areas like crisis care or vulnerable victims, We state that we found that, forces agreed it, we state it, although it's not necessarily critical as the comparative risks, it's probably proportionate that is a lower focus than, for example, restraining people in crisis, which of course can lead to tragedies and the like. So that's leadership. Next slide, please. We then look at what services are available and what their capacity is like. We found that the services relating to mental health are broad and funded by a range of partners, including specifically commissioned NHS services, but also general access NHS services. We found local authorities funding things, police forces themselves, the police and crime commissioner offices, and charities and third sector. So a really broad and diverse sources for mental health services. The specifically targeted services usually included or were specific to liaison diversion, which we'll talk about a little bit more later, custody healthcare, incident triage, and provision of appropriate adults. We did find further 4 specific initiatives that were bespoke and local, but common ones were veteran support, for example, or working with DA offenders on their mental health. We found quite a lot of variation, even within forces, but definitely between forces, really the extent of coverage and concerning variation in relation to referrals to professionals. So just to give a little flavour to that, if you look at people who at when in custody, they identified as having mental health, and that's the full spectrum of mental health, 64% across the whole inspection saw a healthcare professional, but that varied from 40 to 70%. And there were other examples of that variation that aren't particularly explained by policing. And we found an improved position on the space for assessments of mental health detentions generally, but there are barriers to access them, and it wasn't universal. We found one force where it was still really problematic, so that could be not uncommon across the country. Next slide, please. Just now into how officers make decisions and what diversion opportunities are available. Just to stress at the beginning, there's a difference between diverting from prosecution for a given offence and diverting from offending more generally, and we covered both. We found a good awareness from officers of their ability to balance mental health and offending and prioritise care where appropriate, and that can be on the street. It can also be in custody, and it can also be beyond as the case progresses. But we did find a lack of oversight if officers discontinue crimes, and that leads to a recommendation I'll talk about in a bit. Really good screening of detainees in custody and focus on vulnerability. That's not just an initial screening, that's ongoing screening and pre-release screening, which is an area where it can cause problems. So people who are in danger of committing self-harm but aren't suitable for mental health assessments, which we explain in the report, police have to manage that risk as best they can and do a good job in very difficult circumstances. We found quite a few initiatives. In 50% of the forces, there was either a mentally vulnerable offender panel, a group of partners who discuss criminal cases and how they should be progressed in the context of mental health, and 2 examples of deferred charge and caution schemes, where it says what it says. The charge or caution is deferred while they engage with quite an intensive programme. Many offences, the decision sits with the CPS, and as Justin alluded to, there are serious shortfalls in how that information is passed from police to the CPS decision makers. And as I said, diversion from offending is different to diversion from prosecution. The first points were generally around diversion from prosecution. Diversion from offending, there are varied and extensive pathways from formal programmes like the MAPA programme and integrated offender management, down to safer neighbourhood officers having access to services. So really broad, not brilliantly coordinated, a little bit disparate. And of course, they're limited by whether people engage with those services and the capacity of those services, because often or most times access is based on clinical need, and the fact that the police have diverted someone doesn't necessarily mean they should jump any queues. And next slide, please. That leads us nicely. Hopefully these will then make sense into our recommendations for policing. Training for dedicated investigators. General awareness amongst police officers is okay, but for the people who deal and dispose of cases all the time, there was a training gap. We want to policing to sample those cases that are discontinued that I alluded to. There's a couple of codes that are mentioned in the report that are quite technical, but when police close a case that potentially because of mental health, we found quite significant variety in the thresholds for those and asked police to look into them. Review the mental health flagging, which isn't great, and make better use of data. Assure that risks and vulnerabilities identified in all cases, including VA. When I spoke earlier about variety in accessing healthcare or liaison or diversion, that is exacerbated when it's a voluntary attendance case, someone who doesn't go into custody, but who comes in for an interview. So there's work to be done there. And lastly, and possibly a simple but really impactful one, is to review case papers, basically the forms that officers and the CPS use, to include a dedicated prompt and space for these vulnerabilities to make sure that they get included. And that covers everything that we cover for policing. I think we're moving on to a liaison and diversion slide.
Yes, thanks, Tony. If you could cover that now.
Yeah, no problem at all. Liaison and diversion was an area inspected across policing, or the police inspectorate, and the healthcare inspectorates, either the Care Quality Commission or the Welsh equivalent. Really pleased to see that it's universally in existence, as in it's been rolled out. Quite a large sort of sample area. We found that liaison and diversion was consistent with national expectations, but provided core services only. So often very custody based and about that detention rather than that period of detention rather than broader issues. We found stretched resources with staff wanting more. Many staff were multi sort of disciplinary skilled. There wasn't universal cover for hours or days of the week, and not always every police station, for example, which obviously lessened the impact of services provided. However, the staff we did find entirely passionate, dedicated, and had got good access to training resources and felt empowered to do their job. And just reiterating the common theme that both Justin and I have already mentioned, the need for better information sharing, the concern that data protection might apply, and things like that. That led to a couple of liaison and diversion specific recommendations for local criminal justice boards to ensure that L&D mental health assessments undertaken in custody are provided to the CPS, goes to information sharing and defence lawyers as well, to help inform charging decisions, representations for diversion and sentencing decisions, and lastly that Her Majesty's Courts and Tribunal Service should ensure that L&D teams are included in a local liaison arrangements to improve understanding of the provision and joint working relationships. So that's everything that was liaison and diversion.
Many thanks, Tony. There'll be plenty of time for questions and answers on that content at the end of the presentation. But in the meantime, Avtar, you're going to take us through to the next stage of the process, prosecution and call.
Thank you. So here, 30 case files were reviewed by the inspectors, and we also had support from HMICFRS, who further reviewed additional court files to make judgments on whether there were any themes. And as you can see, in total, 63 staff were interviewed. And again, in terms of the findings, the gaps were that often there wasn't a complete picture to help prosecutors with charging. The advice that they were being provided was incomplete, and often the information was not totally relevant. In terms of the quality of information that the Crown Prosecution Service received, they reported that this was variable amongst the police forces. On a positive, every Crown Prosecution area does have at least one mental health single point of contact who has that expertise and can be a good reference point. And you'll have seen that there is a theme that is developing around information sharing, and here it was a similar story in that information sharing combined with a misunderstanding of GDPR was actually resulting in pretty significant difficulties, and we felt that that's an area that needs to improve. And also often people coming to the attention of the courts are underrepresented, and we found that there were actually far too many unrepresented people with mental health difficulties and needs who were coming before the court. So we came to the conclusion that as far as the probation service is concerned, given that the probation service produces reports and it's important that it has the best information possible, that there does need to be a multi-agency memorandum of understanding on information sharing developed. And for the tribunal service, there needs to be an improvement in the arrangements for the commissioning and monitoring of psychiatric reports in order to ensure that there are no, or to limit delays in sentencing. And finally, in terms of the Ministry of Justice and the Home Office, we suggest again that a multi-agency memorandum of understanding, again on information sharing, is produced in order to promote better joint working with a view to achieving better outcomes for people with mental health needs. Now, I'm going to pass on to Charlie, who's going to speak about the prison and resettlement findings. So thank you, Charlie.
That's great. Thank you very much indeed, Avtar. I hope everybody can hear me loud and clear. We visited 6 prisons. We looked at a number of prisoners' file. We talked to nearly 100 staff across the board, really, from operational staff to governors to people within healthcare. There are certainly some positive pictures when it comes to mental health that we see. Assessments are definitely taking place and are quite effective. We're seeing good quality clinical notes and some good information sharing going on. However, at times what's getting in the way of that, I think, is people just misunderstanding the constraints of GDPR and therefore not sharing things that they ought to be sharing. I think our biggest concern that we've come across, and it's an ongoing concern with every inspection that we do, is prison being used as a place of safety. So people ending up being locked in prison for fairly trivial offences because the courts simply have nowhere else that they feel is safe to put them. It's absolutely right that these people who used to often end up in police custody get moved away from police custody, but it's an enormous concern when we see them ending up in prison. And we see this particularly happening in women's prisons, where we had one case where a woman had attempted to take her own life on 2 or 3 occasions, and I think was being put in custody for a public nuisance type offence. Mental health services were very restricted during COVID, not surprisingly, and that meant assessments were being done by phone or not at all, or through doors. Things are beginning to open up a bit now, but as a result, there are still some backlogs in place. We've got lots of concerns about the quality of resettlement. I think with unification going on now and the joined upness of different services, particularly for prisoners who've been on remand, there's lots of work to be done in terms of improving and making sure that seamless transfer between people from custody into the community takes place. And then finally, again, another ongoing and major concern for us is the number of extremely unwell prisoners who need urgent transfer to secure mental health inpatient. We know in some parts of the country, for example, the West Midlands, they've actually got a pretty good track record of making those transfers work. But we also know elsewhere, for example, in London, where we have some big concerns. I was in Wormwood Scrubs over the course of the summer and in HMP Thameside just last week. in both jails some seriously unwell people who are being looked after by some staff members who are trying to do their best, but they don't have the skills, they don't have the training, they're fully aware of that. And patients are being looked after in what are very often completely unsuitable conditions, and sometimes sadly in the segregation units, because that's the only place where the prison feels they can be kept safe. We go on to the next slide then on recommendations, please. Thank you very much. Following straight on from that, the guidelines are that people should be moved within 28 days to hospital treatment, and we think this is essential for prisons. It's a huge burden on the prison service, and that needs to change. We're very unwell people for spending too long in prison. We're extremely concerned about the inappropriate use of prison as a place of safety, and we strongly feel that needs to change. Alternatives need to be in place for prisoners. And finally, the long waiting lists caused by the COVID pandemic continue to give us cause for concern, both inside prisons, but also more importantly for people leaving custody. So those are the 3 recommendations from us. So that's me finished, Justin.
Thanks, Charlie. I know you have to leave us early, so we thought maybe you could take questions now on the prisons aspects of the inspection, if you're able to do that.
Delighted, so absolutely delighted, yeah.
People could post your questions in the chat line, or else raise your yellow hand, and I'll make sure you get a chance to ask them. Maybe while people are doing that, we could just explore a few points, Charlie. Can you just say a bit about how you look at mental health in your sort of routine local reports, and what's coming out of your local prison inspection reports?
Yeah, I mean, these funnily enough, I've just come hot foot from HMP Durham today, and which is again a big local prison. There are a lot of very unwell people who are ending up in prison. They put a huge strain on the system, and often in almost all the prisons we come across, there simply isn't the capacity to be able to offer prisoners what they need who are this unwell. We're consistently impressed in local prisons by the dedication of staff, both mental health staff and also prison staff, to try and meet the needs of these people, but all too often there just simply isn't the capacity, that the facilities aren't right in order to give the treatment that these people need.
And you mentioned that West Midlands was doing a bit better than some of the other prisons in transferring people within the 14-day or 28. Do we know how they're able to achieve that?
Yeah, I mean, I think one of the things I think it's partly, as these things often are, that there are some good relationships in place there. I think also that the provider is the same provider of provision within prisons, and also within the mental health provider in the community as well. So there just seems to be a way of doing it seamlessly. But it also appears that there may just be slightly less pressure on beds there, notwithstanding the fact there's huge pressure everywhere, but slightly less pressure on beds there than perhaps there is elsewhere in the country.
I don't know if you know the answer to this, Charlie, but we've had a question from Adam Rance, who asks, is the NHS likely to be commissioning or building capacity for more secure mental health units in the future? Do we have a sense of that side?
We don't, in terms of the longer term plans. I mean, this is something that we raise consistently. I mean, this is a burden that's placed on prisons that ought really to be a burden that's shared with the health service, because otherwise we're seeing people who aren't getting better in prison, and I think that's the real concern. And there are so many of them who are in this cycle of getting out of prison or going into prison, perhaps getting some sort of stability, perhaps getting some sort of mental health support. I met a guy only yesterday in Durham who had just been released from a mental hospital, had been getting treatment, and then just a few days later he was back in prison again. And that was very much been the cycle of his life for a number of years. So mental hospital for a bit, out into the community, back into prison again.
And we quote a figure in the report that there's been a 73% reduction in the number of mental health beds over the last 30 years. And I think that's continued. So the numbers come down 20,000 since 2009. And that was a byproduct of that is the lack of space to transfer people from prison. And the other issue we're talking about, which is people being held in custody while they wait for a psychiatric report on remand because judges don't have anywhere else to
absolutely right. And I don't think any of us would be advocating a return to the kind of giant Victorian style asylum that used to be around, and that we know there's some brilliant treatment within the community as well, but nevertheless there are people in custody who shouldn't be in custody. They should be in hospital.
We've had a comment from David Breakspear saying recommendations are one thing, being implemented is another. However, we can't expect prisoners to afford to fund all the recommendations themselves from their budgets. Do we think we'll see extra funding? How do prisoners do in the spending review, Charlie?
There is new money coming in to prisons within the spending review. Obviously, part of that is being spent on increased capacity. There's a sense that as more police get recruited, that in effect more people will be going into prison. So I think part of that money will be taken up with new capacity. But certainly we will continue to make the case for making sure that there's better treatment for people with mental health needs in prison.
A question from Desley Dennis, who asks, I'm interested in the mental health assessments in prison with substance misuse cohorts. In the community, we still face challenges accessing mental health services due to drug use, but is that less of an issue in prisons?
Well, I guess it is and it isn't. What's good is that because the prisoner is there, there is the opportunity to be able to do those assessments. And actually, in the really good prisons we go to, we see mental health services and substance misuse services working really closely together. Where that happens, actually, the provision is good and joined up and works well. I think what we sometimes see in prisons is good people working hard, but cogs spinning independently of each other. But where we see mental health and substance misuse working together, we certainly see more effective provision.
And the amount of dual diagnosis is obviously a huge issue. I think we've recently done a report on drug treatment services for people in the system. I think there's something like 50,000 people in the prison system needing some sort of drug treatment for their substance abuse problem, and that's very often on top of a mental health issue as well. So yeah,
and I think the sort of that sort of self-medication, I think for mental health difficulties, and I think the problems that leads to with people perhaps being erratic about taking medication, those sorts of things. In fact, the guy I was talking about who'd come from a mental hospital into prison had also come in with illegal substances as well. So that was a kind of classic case of someone mentally ill, but who was also involved with substance misuse as well.
Thanks, John. I haven't got any more questions, but thank you ever so much for coming today and for talking us through the prison findings. That was great to have you with us.
Thank you. Absolute pleasure. Thanks very much, Justin. Thanks, everybody.
Avtar, we'll move on to probation now. Back to you.
Wonderful. Thank you. So as far as probation was concerned, we reviewed 60 probation cases, which included a number of criteria, ethnicity, offence type, seriousness, etc. And we carried out interviews with over 170 staff. And among those staff, we spoke to strategic leaders, learning and development managers, probation practitioners, staff who were delivering mental health programs, and also psychologists, both clinical and forensic. And what we found was that there was undoubtedly a commitment from the leadership, and there were priorities that had been identified for improving work with people who had mental health needs. However, what we found was that application, that being translated into local policy, was actually lacking, and that was an area that needed attention. So the national strategic drive and priorities were there, but they weren't always making an impact, having an impact on localities and local policies. Again, we found there were gaps in the knowledge, understanding, experience of probation practitioners, and they really needed to be better equipped with skills that would enable them to have the confidence to speak about mental health issues. And we did find that when considering conversations with men and women, there were differences and there were issues there. But we concluded that more skills development was needed in that area. As we have been saying, the COVID pandemic has had a significant impact on services, and this has led to actually a shortage of high quality services being delivered. And we also found that relationships between probation services and those providers of health varied widely. In terms of individual cases, again, we found a mixed picture. There was good evidence of practitioners taking into account the personal circumstances of individuals. However, a comprehensive analysis of mental health needs was only found in just under half of the inspected cases. And the reorganization of the probation service, we believe, presents a genuine opportunity for senior leaders and others to review national strategies and policies and ensure that they are translated into effective practice and carried forward. There is an opportunity here to reset in the new organisation. Next slide, please. In terms of the strengths that we found within probation delivery was that the introduction and development of what is known as the intensive intervention and risk management service offering casework by a psychologist was truly welcomed by practitioners, and we were pleased to see that this enhancement was taking place more and more across England and Wales. We felt that there was a strength in the establishment of a number of community sentence treatment requirement sites, and these had led to an increase in the number of mental health treatment requirement orders, and we support that and believe that would add value and help people who are experiencing mental health needs. And finally, we concluded that a strength was that the use of clinical supervision being provided by psychologists to support practitioners was proving to be really valuable. And in terms of those areas that need improvement and further attention was around the accurate identification of mental health. We found that across the areas that we visited, there was a huge variance ranging from single-figure percentages to double-figure percentages in terms of whether the organisation flagged a particular mental health need. So there is a need to work on how to accurately identify mental health, and that will hopefully support the best services for that individual. From a learning and development perspective, this is for all grades of staff, also PQIP learners across the probation practitioner grade. We feel that this is an area that needs to be addressed. We've spoken a lot about GDPR and the assumptions within that particular process, and we think that there are misunderstandings, and those need to be fixed if there's going to be good information exchange to best meet the needs of individuals. And an area for improvement we found was that as far as services and interventions for Black, Asian and minority ethnic people were concerned, they were lacking and incomplete. Next slide, please. We did find some examples of good practice, and here is one of a man who was coming to the end of his custodial sentence, Kareem, and whilst he was in prison, his probation officer had maintained good contact with him through video conferencing, letters, and a face-to-face visit when that was allowed. The communication between the probation officer, resettlement and other custodial staffs was really effective, and Kareem was struggling emotionally in prison due to the loss of his father while he was serving his sentence. This had led him to access support from a prison chaplain and the mental health team. It became apparent that Kareem's mental health needs were far, far greater than had initially been identified, and that there was a further risk of offending and self-harm. So, having been notified that Kareem would be placed on a waiting list for counselling, which we've heard has been the result of the pandemic, his probation officer contacted the local mosque at Kareem's request to secure some continuity in his mental health care. And on release, Kareem was met by a worshipper from the mosque and offered a hot meal. His probation officer joined the meeting to ensure that Kareem was happy with the support that was going to be offered. And in the meantime, Kareem was provided with information about online mental health support as well. And these two measures, we felt, were used creatively to improve and enhance his mental health and well-being. Next slide, please. In terms of recommendations, there are two that we feel that would be particularly helpful for the probation service. And one is there is an urgent need to review the mental health guidance to help probation practitioners to identify and accurately record a person's mental health needs. We actually found in our conversations with practitioners that some did not know that there was guidance in place. So there is an urgent need for a review of that. And we also are recommending that the probation service should work with the Welsh Government, NHS Wales, NHS England, an improvement, the courts to increase the use of mental health treatment requirements across England and Wales, because we have heard some really positive stories about the impact and how those interventions are particularly helping people with mental health needs. Okay, Justin.
Thank you very much, Avtar. Again, we'll have time for questions on that in a minute, but our final part of the presentation comes from Dr. Sarah Lewis from Penal Reform Solutions, who did some great and very powerful work collecting the testimonies of people going through the system, and she's going to talk us through that now.
Good afternoon, everyone. It's great to be here, and I'm the director of Penal Reform Solutions, and we had a fantastic group of researchers on this project, all of which had lived experience of either probation or prison, and we completed the service user report for the mental health thematic. So next slide, please. So the aim of the report was really to capture the voices of service users and exploring the impact the criminal justice system had on their mental health, and really trying to capture that throughout the journey. So our sample was 67 participants, and we tried to draw samples throughout that kind of journey so that we were able to kind of really illuminate the different experiences that people were having from arrest all the way through to off license and throughout their kind of sentence. So we had 16 in prison, 22 on community orders, 22 on license, and 8 that were off license. I think it's important to maybe note that 9% of the participants disclosed that they were autistic or on the autistic spectrum. And in terms of ethnicity, 70% of the participants we interviewed and that took part in the research were white British, with the remaining coming from a variety of ethnic backgrounds. We had 3 kind of key methods in terms of capturing the voices of the service users. We had structured interviews that were done online. We involved the prison community by putting a notice out on Inside Time to ask people to write to us and talk to us about their experiences in prison. And we created a creative project, which was basically giving people the freedom to articulate their views around mental health and criminal justice system in any creative way that they felt, whether that was poetry, whether that was 5-word stories, or whether that was artwork. Next slide, please. So I'm just going to talk you through the kind of key themes that emerged from the report. You can find the report on our website in terms of its full length, but the first theme, which was really central to the entire thematic, really was relationships. And what we found from our participants was that there seemed to be an absence of relationships and quite a disconnection with people, both at the beginning of their kind of journey, whether that was in the police custody or whether that was in court. And these relationships seem to evolve and deepen a little bit as they went through that kind of journey, particularly looking at those relationships in probation, with one participant stating, "My probation officer is my rock, they're the person that I can rely on." So what we found was when those relationships were positive, people were more likely to disclose mental health and be honest about their difficulties, and it really allowed them to have a voice, to voice their needs, so that they could really articulate some of the problems that they were going through. This, I guess, is very much connected with the second theme, was about creating a safe space, and that was about the relationships created. So by having those positive relationships, people felt that they could talk about their mental health. But if they didn't have that and they were in a very kind of dark space in terms of their mental health, they found that very difficult to maybe articulate and kind of raise their hand to say that they had a problem with mental health. And a lot of the time they felt that they were the ones that were responsible for raising their hand and talking about it. And that was really difficult for a lot of people that we talked with. Safe space also was around the physical environment. So one participant said, I just need a safe space to cry. And this was very prevalent in the work that we did, in the research we got from prisons. A lot of people talking about the benefits of having a single cell so that they could have that environment, which was theirs, and a space where they could be vulnerable because they didn't feel that they could maybe be vulnerable outside of that cell. Trauma was quite a difficult theme, really, from our perspective, in terms of listening to some of the stories about how the criminal justice system contributed to experiences of trauma. People described their experiences as shocking, fearful, panicking, exhausting, confusing, scary, and very much looked at how trauma could almost be kind of reignited from their past by a number of different experiences that they had along the way in terms of their criminal justice experience, not only in terms of their personal ones, but also witnessing the trauma of others, for example, people self-harming within prison. Again, what was interesting is that a lot of people talked about trauma, but very much in the past tense. So it was almost like they weren't aware that that was taking place during their time, for example, in custody or on probation or in court. But when looking back, they could reflect on the impact that it had on them and how it eroded their kind of mental health over the course of that journey. Humanity was heavily linked to relationships. And again, there was a real finding that small things matter. So gestures of kindness were seen as really powerful, particularly as there was a real sense from our participants that they didn't feel that they were deserving of humanity and they were deserving of decent relationships. So when these kind of acts of kindness took place, and when people went the extra mile, and when people went on training to understand, for example, one of our participants who was autistic, that was symbolically meant something really significant for those individuals. And yet on the flip side, those kind of dehumanizing acts contributed to those experiences of trauma and really reinforced that idea that they were broken, or they were lost cause, or that they were criminal or undeserving in that kind of way. What we found was that when mental health seemed to be particularly visible, so again, when people raised their hands, when they talked about their problems, humanity seemed to follow a lot more readily than if it was hidden, though this was unequally positioned, particularly when people were particularly difficult in terms of their behaviours, the nature of their offending, as well as being known to the criminal justice system. So whether that was about having a number of, a great history of arrest or being in prison a number of times, it almost seemed that as people became more frequent in those kind of systems, then with that humanity seemed to erode a little bit, and tolerance as well. The need for certainty was again something that really came through, and that reinforces some of the stuff that Avtar and Justin talked about earlier. A real sense of confusion and a lack of clarity, which again must come from kind of experiencing issues with mental health, but that was really exacerbated when they didn't know what was going on. They didn't know the reasons maybe why they were in court, and they didn't fully understand the sentence that they'd been given. And a lack of certainty was also the case when people were waiting for long periods of time. So, for example, when they're on remand or on bail for long periods of time, this really just seemed to be a kind of heavy burden on them during that time, because they didn't know what was happening and they didn't know what the outcome was going to be. Well, stepping back, I guess, in terms of these relationships and moving on to the next theme, which was about the faith in the criminal justice system. So it seemed that when they had these positive relationships, that kind of created a kind of faith in the system that enabled them to work better within it, to comply, to engage more heavily. But a lot of people talked about a kind of sense of abandonment and a disconnection, and these poor relationships seem to lead to a kind of erosion of legitimacy of the criminal justice on broader levels. Again, hope and hopelessness link in very much to those kind of relationships in terms of people giving individuals hope, and also that kind of sense of hopelessness for some people when they kind of press that self-destruction button, or when they felt that they had to give, they wanted to give up on life, which was something that one participant said when he got arrested. Again, IPP sentenced prisoner talked about that kind of hopelessness and that level of kind of uncertainty, and how when you added these kind of different layers on, it became a really difficult and kind of desperate experience for those in terms of their mental health experiences. In Search of Meaning was another theme that came from the data, and that was about how people and relationships help.
Sarah, you've gone on mute.
Sorry, that's bizarre. When did you lose me, Avtar?
Only about 20 seconds ago. So if you just start with the last two sentences, I think we'll be back.
Brilliant. Okay, so one of our themes was around In Search of Meaning, and that was very much about how people. Thanks, Avtar. People within the criminal justice system, whether that was teachers or probation officers, assisted individuals to kind of find their purpose and find their meaning. And this seemed to give them greater hope, and it seemed to alleviate some of their feelings, some of their difficulties around mental health. But also COVID seemed to have had a real impact, particularly in prisons, where there was a loss of meaning because so much was stripped away from them, and they were experiencing that kind of real solitary kind of confinement during COVID. That again led to kind of a deterioration of their mental health. So meaningful spaces seem to be these safe spaces. So again, therapeutic communities were talked about in terms of creating a space where people could be themselves and could talk about their issues readily. The last theme that came through from our findings was that of diversity and inclusion. And what we tended to find, again, in the small sample that we talked to, was those from ethnic backgrounds talked about a kind of cultural pride and therefore not disclosing mental health, and in some senses almost subcontracting that out, so not relying on the criminal justice system due to their lack of faith within it, but very much trying to find help, whether that was through their GP, whether that was through independent rehab. It was ultimately about how they were going to navigate the system so that they maybe didn't trust as much because of this kind of fear of being judged and a fear of there being a bias in light of maybe their age, their race, or their gender. So in some senses that diversity was really important in terms of getting people to talk honestly about how their experiences of mental health within the criminal justice system, so that those kind of right supports could be in place that meets the needs of those individuals. So if we just go to the last slide, and this is just a little bit about, I guess, our solutions. You can find our report in terms of the specific kind of solutions we kind of proposed for the police, probation and prisons. But as a broad kind of suggestion, we talked a lot about the importance of training and awareness and the support for staff. A lot of staff trying hard, but maybe not having the time or the resources in order to deal with the kind of complex difficulties associated with mental health. A greater attention on relationships, and ultimately that relationships are a real powerful vehicle to alleviate mental health issues and to enable people a safe space where they can grow, and to find creative ways to reach those that are hard to reach, that maybe those that aren't willing to talk about their mental health, how we can do that creatively in the future, whether that's through digital technology, whether that's through social media, but different ways in which we can kind of reach people to find out what's going on for them and the realities that they're facing, and also to build certainty throughout the system. So whether that's about providing information, whether that's about explaining processes and outcomes, and doing that very much in a kind of procedurally just way. But, you know, on reflections, I think the team that we had on this thematic would share certainly my thoughts around the experience as a whole. We found it very humbling. We found it really enlightening, and we felt privileged that people could share with us their stories, and that we created a safe enough space for them to talk about that. So I'm just going to hand over to Justin, who's going to talk about next steps and Q&A.
Thank you very much, Sarah. Thank you ever so much to you and to all of your team of interviewers for the evidence that you gathered. I know it had a huge impact on the inspection team, and you were reporting back what you found every week as the team met, and that was a really important part of those meetings. And as you say, there are lots more stories in your report, which you can find on our website as well as on your Penal Reform Solutions website, and we've woven in some of the quotes from what you found into the main report as well. And I think your point about creating a safe space for people to talk about these issues is so important, and relying on people to put their hand up when they're often in crisis or feeling threatened or feeling very vulnerable just isn't the way really to do this. You have to create spaces where people have the confidence to disclose and to ask for help and to work with others. Right, next steps. Our full report is available on our website. I don't know, maybe Lauren, you could send around the link on the chat line so people can click into it. We are hoping also to produce an effective practice guide, because we did find examples of some good things as we went around the 6 fieldwork areas, and we'll keep people posted on when that will be coming out. Right, we've got potentially 15 minutes, just under 15 minutes for questions and further discussions. And I see there are already some questions going into the chat line, but do also raise your yellow hand if you'd like to ask a question as well. There's a question from Darlington Chiofu. I hope I've said your surname right, Darlington. Talking about psychologists in prisons and saying that they are limited to different therapies compared to those working in mental health services. Is it something that prisons need to review so that a wider variety of therapies can be offered? I'm afraid I think we've lost Charlie Taylor, so we haven't got a prisons inspectorate representative. But Avtar, I know we found it was actually very difficult for any sorts of treatments to be delivered during lockdown in prisons, wasn't it? All group work, all individual face-to-face work stopped. So I think psychologists found it tough over the last 12 months to deliver any sort of interventions. But did you get a sense of what was available or what might be done?
In terms of what was available, it was mostly remote. In some prisons, not all, there is an in-cell telephony system where people who are in custody are able to make calls, and others are able to call in. So that was the main intervention. It was one-to-one. There wasn't really that much group work that we found, because the period that we covered was mostly during lockdown.
I just saw that Tanya put your hand up. I don't know, Tanya, whether you're able to.
Hi, I just thought I'd better let you know I was here.
Did you see the question about psychology services in prisons?
Yes, that's why I kind of identified myself quietly sitting here listening. Yeah, so sorry, I've got a really bad connection, so I'm not putting my camera on. But basically, there are two different types of psychology services within prisons, and maybe there's a bit of misunderstanding that there's psychology services for people who are required to do psychological interventions for their rehabilitation and reducing reoffending, and then there's psychology within the mental health services. So there are in some of the sites we go to, there are definitely psychological interventions for what we would expect to see would be psychological interventions for people to meet their mental health needs. So we would expect to see, treatments for severe trauma and for, PTSD. So we just don't see the consistency within all of the commission services. So we would expect there to be a needs assessment for each prison, and then if there's a high need and there's the capability of the service should be able to meet those needs. We haven't found that in all places. Just so it's clear that there's two different types of psychological.
Yeah, that's helpful clarification. Thanks for that, Tanya. Andrew Bates, thank you for your comment and question. You note from the thematic inspection that there's no common definition of mental health used across the criminal justice system, and that's leading to inconsistencies. And we certainly found that Lord Bradley over 10 years ago recommended there should be a common definition. That recommendation still hasn't been enacted, and we think it's badly needed, and it's leading to people being missed and to huge variations in flagging practice, both within and between agencies. I don't know, Andrew, did you want to add to your observation?
Well, it's just to echo the point, really, Justin, about I think that what I'm driving for locally where I am in the South Central area is more systematic screening to generate information, because even within the organisation, there are different understandings of terminology. And it seems to me if we can implement screening across mental health and also autism and neurodiversity, an area I've been closely involved in, then, even if we're only generating data that another agencies say, well, we wouldn't pay regard to that, that's still below our threshold, we'd then be in a position where we could say, well, what is your threshold? What screening tool do you use? And at the moment, I discussed this with Avtar at some length earlier this year. We're going to go round and round in circles unless we can have a definite lines in the sand about what we mean about various concepts. Interestingly, the case study of Kareem that we mentioned earlier, I can pretty much say that I very much doubt that person will be considered mentally unwell by a community mental health team, even though they might be, and they may cause issues within a prison setting which are responded to, but in other contexts that they wouldn't meet the threshold for services. And this is a continuing problem.
Thanks, Andrew. Yeah, I mean, we very much felt that. And I think that we found lots of different assessments being used by different agencies. We found huge I mean, just to give you an example, I mean, Avtar mentioned how much variation there was in probation practice around flagging. One area we found 1% of cases flagged with mental health. Another it was 25%. And I think you could probably find similar things in the police and potentially prisons as well. Christine Cowell, I hope I've said your surname right. Mental health is evidentially complex. It aligns with other protected characteristics. Was there an opportunity for exploring the impact of mental health from the perspective of other identifiable characteristics and identities, for example, age or race or religion? Avtar.
Yeah, so in our report, you'll be able to see the breakdown of the various demographies in terms of age, ethnicity, and certainly we did try to ensure that there was a good sample across the 60 cases that we selected. So the answer to the question is yes, we did. And within the report, we do report on some stories. Ordinarily, we found that services for women were better. We found that for Black, Asian, minority ethnic people, there were no real specialist services, and we suggested that there are organisations in the community. The Race Equality Foundation has produced a directory of local and national sources that practitioners can tap into. So the answer is that yes, we did look at those different profiles in terms of gender and ethnicity, and you'll be able to find detail in our report.
Thanks, Avtar. Andrew Blythe says extremely important points made, but seemingly focus on adults, equally important, if not more so, for children and the children's secure estate. I mean, it's a fair point, Andrew. The scope was deliberately restricted to adults, and there is a need probably for something similar around children. It is a different set of stakeholders. We start getting into children's services, CAMS, yacht provision, and all the rest of it. But it's one for a future day, but certainly something we need to keep an eye on as well. Carl Halliwell, this is probably for you, Tony, could more be done to prevent people possibly unwell being arrested and taken to a police station? Was there a sense that the police NHS initiatives were working? Are police too quick to arrest or take to custody, as alternatives are too time intensive for police officers? And then secondary, in PACE, isn't the definition used in the Mental Health Act used to determine mental health need and vulnerability?
Thanks, Justin, and thank Carl. Lots in the first part of the question, although not directly attributable to that question. Just to reiterate that the use of police custody as a place of safety under Section 136 of the Mental Health Act has almost been eliminated completely. Has been for children and very, very rare in extreme circumstances for adults. Then you get into arresting for criminal offences. A couple of things to say on that. You may or may not be aware that over the last 10, 15 years, arrest rates have generally been going down across the country. That's because police have started to buy into both sort of policy and legislatively, and also conceptually, the benefits of not arresting people and using things like voluntary attendance. There's more of a reluctance in policing to arrest generally, and a lot of focus on vulnerability. We then have things that I alluded to in my presentation that we call street triage, but are usually control room based triage, which is where either mental health practitioners or social workers are based in control rooms and are advising officers on the best course of action in relation to detention under the Mental Health Act or arrest, etc., etc. So in general, I would say that police aren't too ready to arrest, but one thing that is worthy of note is the police are, and this is, I think, a statement of fact, the agency of last resort. So when you've got someone who simply can't go anywhere else, i.e. their drugs and alcohol mean they're mixed with their mental health, means they can't be seen, they're too violent, etc., etc., and you have substantive offences, even if they're public order offences or assaults, the way that police can manage that risk to the person or to others is to arrest them for a crime, and that definitely happens. And in the last point, PACE defined, the definition of vulnerability in PACE changed a couple of years ago, and that actually comes out of our report because we're not sure the risk assessments have changed to it. It's about, or in the context that we inspected upon it, it's about how vulnerable the person is in relation to whether they need an appropriate adult and support within the investigative or custody environment. And it's about how they can be influenced, how susceptible they are, if they're easily led, if they get confused and things like that. It's not a term about mental health, although it says that mental health can be a cause for that vulnerability. And I'm not sure of mental health personally being defined in PACE at all.
Thanks, Tony. I think we're nearly out of time. I haven't got more questions in the chat line. Thanks to David Breakspear for your comments in the chat line. I'm glad you found the PRS input helpful. I think that was some really powerful stuff in there. Can I thank everyone who has dialed into today to hear this launch presentation? It's great to have had you with us. Can I say many thanks to our presenters, to Avtar and to Tony and to Charlie and to Sarah. And thank you to all of their teams. This was a huge team effort involving staff from all of the inspectorates. You've heard from Tanya, but there were inspectors from all of the inspectorates, as well as Sarah's interviewers. So we were really grateful for this huge amount of evidence that they were able to gather. The next stage is that the government needs to produce a response to our recommendations. So look out for that. We'll certainly be looking out with interest. I have a chance to present the highlights from this inspection to ministers next week. We've been given a spot on the Ministerial Deaths in Custody Board to report on our findings. So I'm looking forward to presenting directly to ministers as well. But a really important study, I think, some powerful findings and recommendations. If you haven't had a chance to read it, do go and do that, and look out for the effective practice guide that will be coming soon. Thank you all. Can I wish you all an excellent weekend, and look out for our next event. Thanks all.
Thank you.